up the cool graphic and everything. So, little PCR class is what we've been asked to talk about. And when we talk about the PCR, and you guys are going to share this with other folks, so by all means ask the questions that have either already been posed to you, like we've already talked about, or any that you guys come up with, try to get through it. Clearly there's lots of different PCRs out there, check boxes, narratives, bubble sheets, and you may have been exposed to various elements of any of those or all of those at one time or another. Oftentimes now a combination of those things are incorporated into our charts. And the obvious question is, why do we even do a patient care record? Well, hopefully we can answer that ourselves, but continuity of care is probably one of the biggest ones as we transfer patients from one care provider to another, one level of care to another. Clearly it's a legal document, which I think is probably one of the biggest drivers for why we put stuff on paper or in a computer, so we can reference it back down the road 3-5 years from now. Clearly administrative purposes, which would include billing, which is a key component to all of our electronic PCRs these days. Things that probably don't get teased out enough from our charting systems, whatever it may look like. Education and research, again, probably as a function of size and of your departments, that to what extent you utilize that feature or that aspect of a charting system. And then the other really big one is quality assurance or quality improvement process, however that looks like in your department. So the other question is, who's going to look at this chart? And clearly other healthcare providers are going to be looking at it, so the docs and the nurses, whoever you're turning your patients over to. The QI folks in your own agency will probably look at it. Hopefully, again, depending on your departments, trainers, educators will be utilizing. Oftentimes these two work tandem together to come up with an education plan. If the QA/QI process identifies an educational need based on chart review or monitors that they're looking at in charts, they'll get hold of the training division and say, hey, we have a need to address this. I imagine to some extent that's why I'm here talking about charts. It's sort of that same process. Somebody identified, hey, we have either inconsistencies in our charting process, or they aren't meeting our expectations, or not everybody's meeting our expectations. How can we make this better? So let's get everybody on the same page with a charting class. So the same thing can happen with starting an IV or doing an intubation or doing whatever. So these two are pretty integral, working with each other. Clearly administration is going to see your charts, and that goes to billing and insurance folks. So again, could be scrutinized, reviewed. Do they meet their check boxes for getting a timely bill out and expecting to get paid from various insurance agencies, governmental or third-party insurance agencies? And again, the insurance aspect of it, including Medicare, can come back and look at the charts or audit a whole bunch of charts and say if this is legit, and this reimbursement that we've given this transporting agency, is it legit? And there's a number of them currently and frequently throughout, where again the feds, the Medicare, comes down for fraudulent billing practices. So we're constantly scrutinized on that level. And then obviously this is a legal document, so lawyers can ultimately and possibly be reviewing this chart, as might your patients. So lots of eyes on this chart over again quite a long period of time, 4 to 7 years potentially, maybe even longer in some situations. So lots of opportunities for it to come back and be used as a reference. And I think with that in mind is why all of us, we put it in paper, we put it in a computer, and you got to look at it as a frame of reference. When it comes to patient care issues specifically, which I think is pretty much on our mind when we're dealing with a call, writing a chart, submitting it to the hospital, incomplete, inaccurate, or ineligible documentation can cause subsequent caregivers to provide inappropriate care to the patient. Just that pass-off deal, which you know how that goes in the hospital, may not always be received well, may fall on deaf ears, that everybody may be busy and yeah, and everything. So the only thing left for them after you guys leave, without that personal communications, or change of shift issues, whatever, is to come back and look at this chart. And therefore, again, there's an opportunity to go down a bad pathway, potentially. So, I think you can see how that goes. And I know everybody feels, well, they never look at our charts anyway. You know, maybe 80% of the time they don't, but the 20% when they are going back and looking at it for a particular reason, they need to. And when you look at these, I think most of us started out on paper. So, and there's two sides to these charting systems, if you will. There clearly is a demographic, administrative, billing side of it, okay? And I'll tell you up front, that's the most important aspect of all of this, because if this doesn't get filled out and your billing department can't send out a timely bill in a timely fashion, you guys aren't going to get paid next week. Is sort of the theory behind it. That may not be true for a fire district, but you get the idea. So clearly this is very, very important information, and it drives the bottom line for most organizations. The other side, the reason that we're here, is the patient care aspect of it, which typically gets laid out into some very basic information, looking at allergies, physical characteristics of the patient, clearly vital signs, chief complaint, all those kind of things. Most charting systems, no matter what they look like, paper or computerized, will have a history of the present illness. This is the circumstances that brought us here. We'll talk more about it in a bit, but this is part of your ample or sample history. That the events that brought us up here, that E, it sort of goes here. Why are we all here? Why'd you call this meeting? Then your physical assessment, which falls into a SOAP charting format as well. So if this history of present illness is part of your sample, events leading up, it's also part of your subjective in a SOAP charting format that many of us or most of us are familiar with. This is that subjective information sort of up in this top half. Here is our objective information. So this is our physical assessment. Now, most charting systems, both paper as well as EPCRs, have a template for this physical assessment. And it comes in different forms. Some of them are watermarked, but they're reminders to hit all the systems. And this is also where you're going to get things like, we'll talk some more about it, the WNL, which in some circles means we never looked, but in other circles it's supposed to mean it's within normal limits. If you have that sort of system that you can use within normal limits, do you? In your charting?
No, guys just do that in their narratives.
Okay.
Well, there's a spot to do it. There's a head to toe. Some guys do it, some guys don't. It's the inconsistency.
What's important if you're going to use WNL is that you have a definition list. What does WNL for respiratory mean? That needs to be part and parcel of it. It also needs to be, if the guys are doing it freestyle and saying within normal limits, the department should come up with, needs to come up with, not should, needs to come up with, what does that mean? You need to have a universal standard. If you're charting respiratory systems, WNL, what does that mean? Does that mean you're clear and equal? Does that mean normal excursion? Does it mean you're well saturated on room air? All the above? What does that mean? So, and again, most charting systems have that built in, but if not, then that's probably a must-do thing for the Department for Clinical Services or whoever would do such a thing, if you're going to allow the guys to do that. And so that would be one of the areas that the first thing you got to do to standardize what does WNL mean for each system if they're prone to using those. Because you could probably ask all three of you guys, what does WNL mean?
It'd be
for
completely
respiratory?
different.
Exactly. So that's really important. Now I could probably defend it on my own in court. Say, well, what does WNL mean? Because I think reading this chart, Mr. Moeller, it means you never looked. Well, no, it means. Where'd you get that? And I said, that's my personal standard. I mean, that's arguable. It'd be a lot better if you had a departmental standard. This is what it means anytime anybody in this department writes it. Then you have a system again in most chartings where you can do more of a narrative flow. And the thing that I'll say as we go through all of this, is that these things should flow like a storybook, top to bottom, chronological order, and that's the way most charting systems are built. That being said, your system's a little bit different in that you have an opportunity to do a bunch of check boxes, and then you get into your narrative, so it's that narrative portion that needs to read like a storybook in chronological fashion, but it'll have some of those key elements we just pointed out in your narrative. You'll probably restate, patient's age and allergies, those kind of things, what their chief complaint is, again, why you were called. You'll probably very early on in your narrative talk about the history of the present illness, what brought us all here. You'll probably do some physical assessment. And again, some cases may be very generalized, cases it may be more focused. That's all okay. You'll probably have in that narrative that you're doing an opportunity, even though you previously restated it, to acknowledge your various treatments, and again flow through after your assessment to, I should be able to see what your plan was. And if obviously that was to treat pain, you treated the pain, I should see that in several areas. Then what were the results of that treatment? And again, it should flow all the way down to the time you get to the hospital.
John, real quick question on that. In your opinion, is it important to document the procedures, the vitals, the treatment, the assessment in that narrative if it's already previously stated, like your assessment that you listed there on the Ramsey chart?
Yeah,
what's your opinion on it?
I got an opinion on it, and let me hold that thought
Okay.
just for 1 second. So, because that's a great question. In your charting system, again, looks very similar, and obviously you had to fill out all this information, patient demographics, and again, that's the stuff that's going to get you paid. One of the things that you'll see, we were just talking off record, comes into play, patient assessment. Obviously these are codes and they're billing codes, and trauma injury. Man, that's pretty broad. So, you're gonna narrow it down, okay, fell. Again, ground level fall, fell from 30 feet off a balcony, lots of questions. And if to start to address your question, to leave that as, this is my assessment, this is the chief complaint, this is what brought us here, is he fell and has a trauma injury, pretty weak. If that's all that you had in this chart, which is a possibility. And so unless you come down here and narrate that, which they did, 89-year-old female, tripped and fell. So it's mechanical ground level fall. Okay, now I got a little better picture of what we're dealing. I'm dealing with LOL, mechanical ground level fall, and it's a trip and fall, it's mechanical. So I got a lot of information from there that I didn't have from a checkbox up ahead. So that should drive you guys why you need to narrate right there. And then you have your assessment and interventions. To a large extent, this is a billing deal. just depends how your billing is set up. So clearly, again, it may be different with public service, but if you want to get paid next week, the more of these legitimate checkboxes you can put in, the better the chances are of getting paid and getting reasonable reimbursement, which is forever changing. So it's helpful to do that and put as many of those checkboxes as you can that make sense. And again, it may not do much for your charting. Where we'll come in for your patient care is all this gets timed, and if you're doing a code, you're doing meds and everything, you'll have a nice chronological time flow and record of that, which gets back to, again, the off-record question of, how much that do I have to put back in my narrative. If this is fairly complete, you can be pretty generic in your narrative, and you can refer back to the flow chart for times, for my meds, those kind of things, because it is there, and But on the clinical side of things, these EPCRs have done very, very, very little for us. So you need to go into it with that up front. And as we go through this now, when you go through with that concept in mind, in my mind, I do the check boxes, and then I'm done. I did that piece, boom, okay, the billing department's happy. Now I get into the narrative and I start my clinical chart. And I go into it with that I may be redundant, because I've done all those check boxes, I've done that flow sheet, and that's okay. I can refer to the flow sheet, but I look at it as a checks and balance. If I forget in my narrative to chart a temperature post-arrest or whatever it is, some little nonsense thing that you've got to do or you should do, and you didn't do it in your narrative, and someone says, hey, you didn't chart a temperature. Well, yeah, I did. It's in my vital signs. Okay, that passes. That's good. So it becomes a checks and balance type thing, and that's how I utilize it and look at it. But I start fresh when I start a narrative. And we'll talk about different charting formats, how to do a narrative. But again, it should be a nice chronological storybook, start to finish. Here's what I did, here's what we were called to, here's what I saw and found when I got there, here's my assessment, here's my plan. I'm going to start an IV and treat for pain per protocol, however you want to state it. And we're going off to the hospital, and oh, by the way, I've got a reassessment in there because I did an intervention and the patient improved. And all that's narrated. And again, on a more complex chart, if you want to refer back to a flow sheet, clearly you can do that. You don't have to maybe put the detail in if you got drug dosages in your flow sheet and those kind of things. You can refer back to it, but again, I'm not opposed, especially if it's pertinent, to putting a dosage in per se. Even though I know it's redundant, I know it's in that flow sheet because it just makes my charting flow nicely. One of the things you guys don't have, so there's a lot of things there. So again, let me get caught back up. We've seen the two elements, if you will, the administrative side of things, the run data, that's again what the billers are going to do, and then the patient data. Patient information, condition, call, and any treatment rendered typically are check boxes in much of the things that we do, but again are going to need to be supported or backed up by that narrative chart. And I think if you'll just get on board and look at the check boxes as one aspect of it, get them done, do them thoroughly, and then put it behind you, and then get back into what probably most of us did initially was chart. Do that narrative charting, however it was you learned it, which is probably SOAP or something like that. We'll talk about those in a little bit. Keep in mind also in all of these charting systems, especially electronic ones, is there's some requirements put on typically by the feds, US DOT, NHTSA, those kind of folks, either regulatory or strongly suggested for data collection. So like NHTSA, Ulstein, cardiac arrest data, those kind of things for doing research, and you can pull them from a national pool. So that information comes in the form of both patient information as well as administrative information, and some of the things that are required on the chart: chief complaint, level of consciousness, You need to have a systolic blood pressure for those greater than 3 years of age, skin perfusion or capillary fill for those less than 6 years of age, skin color and temperature. So again, some of these things are built in, you're kind of forced to get some of these elements, and that's just because they're a requirement, but they're built in and it's not a departmental deal. You can make it, in this day and age of non-invasive blood pressure measurement and everything, why shouldn't you have a departmental policy is we're gonna get a blood pressure on every patient contact we have, AMAs or otherwise. And if you wanna do that, that's fine, then you don't have to worry about that rule. Okay, because it is a federal requirement that you have blood pressures or documentation as to why you don't on anybody over 3. So why don't we just say departmental, we're gonna get blood pressures in every patient contact that we have. On the administrative side of things, run times are probably the biggest one, and then you'll see some other data collection by other agencies in many charting systems, like Mechanism of Injury is a NHTSA deal, and so they tried to build those in there, so if you participate in a data collection, or the Ulstein for cardiac arrest, trying to collect, AED usage, first responder, CPR, those kind of things. And again, don't have to have that information in your charting system, but if you ever want to participate in a national data collection system, and it's pretty easy to build in. And again, some of the things you're paying for in the electronic data collection systems, they've made the decision, we are going to make this a part of our chart, and no, you as a department can't get rid of it. So it becomes either highly suggested or even a critical mandatory field, otherwise you can't submit your chart. Clearly, again, we're collecting demographics, insurance information, and nature of the call. This being said, something that may make some sense to you guys, obviously when we take these patients in, or if you're transferring care, say to a helicopter, CalSTAR, us, doesn't make any difference. You may not have all this information, so you're always, calling us for a face sheet. And that's fine. If CalSTAR takes it, you're probably not going to get a face sheet. What you really want from those guys is the medical record number of the patient. You have whatever information you have, you may or may not have a name, but if you can get a medical record number from that flight crew that took that patient in, or at least get that at the hospital before you leave, then your billing department will probably think they're golden. Many of these billing departments have relationships with the various hospitals that with that simple information, that simple number, that unique identifier, they can tap into their system or easily access the system and get those demographics as they become available through the hospital system, who are way more aggressive, having a lot more time than us to gather insurance information, accurate addresses, those kind of things. So probably the one most important piece, having a name is great, birthday is great, social if you can get it, but any of those, or at least a UIP number if that's the case, and that medical record number, that UIP number, should make your billing department very, very, very happy, because then they can pursue the rest of the information through their sources, and they have way better sources than we do standing in the ER in front of the charge desk trying to get that information. So the medical record number is probably one of the most important pieces of information besides the other stuff that you're routinely gathering. Clearly, and again, these are many checkbox items: mechanism of injury, location of the patient, any treatment rendered prior to arrival are typically handled nicely with check down boxes. If RMS doesn't have those kind of things, these are kind of the things then that you definitely would want to include in your narrative. So, when you look at that list, is there a checkbox for mechanism of injury? Obviously there is. We saw that chief complaint, trauma injury. Again, already stated, that's a little bit broad. Okay, so I think you're probably going to want to refine that in your narrative. So I'm probably going to restate the mechanism of injury. Location of the patient. Could play into a number of different things, especially when you look at occupational injury, work comp type things. You know, was this in a workplace setting, and is this a paid employee type thing? So those kind of things can play into it when you're doing it. And again, may not be captured accurately by those drop-down menus. Treatment rendered prior to arrival. Do you capture that in a drop-down on your list? Pretty
There's drop
easily
downs for that,
and
yeah.
everything.
Yeah.
And this is one, again, not being, actually, I'm only peripherally familiar with RMS and at least 2 versions older than the one that you guys are using. Is something that, again, with that concept, okay, I did the check boxes, I got prior to arrival interventions. Cool. I probably, just because of the way I chart, would hit the highlights of those prior to arrival interventions in my narrative. I don't care if I'm redundant. I'm telling a story. That's what I said. You blank out the fact that I put all those check boxes in. Here's my story. And if prior to arrival interventions are pertinent to my story, I'm probably going to redo them. And it's just the mindset that I have. And I think you have to, with these electronic PCRs, need to adopt to get the information out. Tell your story, just like you initially learned to chart. And again, if you
Isn't that, let's say the engine's with them for 10 minutes.
Yep.
5 to 10.
Yep.
And they do an assessment, initial set of vitals, and initial basic treatments, medications, etc. So
okay.
this is kind of the situation I
Okay.
think Dennis is talking about,
Yep.
because we have many times it's only a minute or two, and I think that what you said may be appropriate
Sure.
because there's not a whole lot done.
So you essentially you've gotten 2 ALS assessments out of the deal
Yeah.
and everything.
I'm more focused on the one where there's some real
Oh yeah.
advanced interventions
Oh,
being
yeah.
done.
Right.
It's a
That's by
code
the
they're
engine
working
company. Okay.
that, you know,
But how is RMS is not set up to deal with that very well then?
No, you have the list, say, you know, these guys are on the engine, and Matt and I are on the rescue.
Right.
And they get there, and they, you know, start a line and do an assessment and blah, blah.
So
You've got a record of who's on the call based on their EMS number and all that stuff. So as a transporting medic, if I get a verbal pass on from these guys, hey man, this is what happened, blah, 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 we did this, this, and this, have a nice day, I can go back and put down that they did it because they're attached to the call already. So is there any reason that you couldn't do that?
and there's
You know, because I see exactly where you're going. You, like I said, you hit the key word. I did this assessment. I've made these interventions on this assessment, and it's interdepartmental. It's your department, your engine crew. You want to write a chart up to the point that they came and took over.
Right, because there's a liability aspect for the
Absolutely. So you absolutely. I think you need to do that in that circumstance clearly, for the exact reasons that you're thinking. I just don't know how to best tell you to do it in RMS.
2 narratives in that call.
Yeah, there would be.
So we're talking about
the
2
engine
narratives.
company doing a narrative and everything, and now, but I imagine because it's all in the same call.
I mean, we were always thinking if it was within a couple minutes and you did basic
Oh yeah.
basic stuff, that could flow into
Yeah.
one. And
Oh, no, I see
I'm
your
thinking
point.
out loud, and I'm thinking the more critical calls where our district stripped, and you got a lot of, I mean, and where there's different
Medications are
thought
full.
process involved in this, you know, and
I just
I'm
don't know
open
how.
to the discussion. I just
So
don't-
clearly, you're absolutely spot on. You as the first responding engine company in this involved call, doing an assessment, doing interventions, waiting for transport. It would be no different than you're waiting for care flight.
Yeah.
Okay, boom, you're waiting for care flight. You're gonna do a chart.
Right.
The difference here is, it's interdepartmental. You
Yes.
got your buds with the same colors coming and picking up the patient. But the same fact holds true, you're obliged, I think, to do a chart and assessment and all that, as is the transporting.
So where's a line that says a verbal pass on is not sufficient, and that
It's gotta be black and white.
right, we got to be able to tell
Be a
guys, and this is kind of a
There's gray area.
operational deal, which we don't want to suck you into.
Is it
But
IV?
where do you draw the line from? Hey, James, I did an assessment. I got an 18 gauge, and I got this, I got that. I gave 50 of fentanyl, and I'm out. Where's the line that says I don't document that they did it? This is what I got from them, versus they go in and do it themselves.
ALS.
That's
I mean, I don't know.
Invasive or meds, I think, might be a starting point. You know,
Vital signs and doing that sample history, which is very familiar to all of us. We're going to document the patient care on all these patients. And what is frequently doesn't happen in EMS charting is changes in patient condition, which also goes to responses to therapies rendered. And that's a very common one left out. And the question was brought up before we started class, well, you know, nursing's different than EMS. Well, no, it's not. We're all given drugs and doing interventions, and we expect a certain response. And that was based on a plan that we set out. Whether it was articulated on paper or not, we had a plan. Did they hurt? We're gonna alleviate that pain. I'm gonna give fentanyl. And then we need to have that reevaluation piece to it. So that's what's really key there and oftentimes is missing. And then clearly, this also goes to a change in patient condition, typically deterioration. Again, in your storybook, you'll be telling that story. You did your initial assessment there on the roadside or somebody's house, you put them in the ambulance and you're going to Cartoon Taco and they crash. Well, after you're someplace in that chronological order, patient crashed. We started to bag the patient, we gave them Narcan or whatever the case may be, and they responded well, got tuned up, and we delivered this living, breathing patient to Carson Tahoe. So it all flows through in your narrative, again, in whatever format style you want, SOAP or DAI or some of the other things we'll talk about. Be really careful in your charting, just some pearls, if you will. Describe, don't conclude or judge. I'm sure you've heard that before, important. Depend on the type of charting systems that you're using or format that you're using in your narrative especially. You want to hit pertinent negatives and positives. Again, before we started class, you know, we were talking about we need departmental standards. You know, what are the expectations for dealing with a chest pain? And some of those are kind of ingrained by in your training, but you have somebody complaining of chest pain, what do you want to know? I mean, that's a question. What do you guys want to know? Chest pain. I got chest pain.
When did it start? Yeah,
OPQRST. So that is one of your standards. You would expect to see that, either positive or negatives. And that's what we're talking about, positive or negatives, for those standards. You're looking at duration, you know, OPQRST is the simplest way to deal with that one. And, you know, you go through that, so include both positive as well as pertinent negatives. And if I'm dealing with an OB case, there should be some sort of guidelines. And again, you all may have your own individual ideas. So something that your clinical committee you've identified you have probably need. What are the expectations of dealing with the OB patient? I'm looking for EDC, I'm looking for prenatal care, gestation, complications, those kind of things that I would expect to see in any OB chart. Gravidipara, abortions, I'd expect to see that in an OB as a departmental standard. This is what I'm looking for. Any problems in the region over the years of putting radio codes in your charting, but apparently in some places that could be an issue. Using only standard or agency approved abbreviations. Do you guys have an abbreviation list?
No.
we used to, more importantly now with RMS, is there's actually symbols we cannot place, such as quotation marks. We have to be more creative and write things out, because when it gets uploaded to the other systems, it scrambles the stuff.
Have you seen that other places too?
Yeah.
Is that common?
Yeah.
No quotation marks?
No, Health EMS can use quotation marks. They got some other glitches in the system, which is a real problem, because one of the things that I'll say a little bit later, if not right here, is, you know, there's a time and a place to use quotation marks and stuff. Absolutely imperative that you do, and it goes to describing, don't conclude or judge, and everything they said, you know. And that's probably how you can deal with it in your system without the quotation mark. They said, and have what they said. And I would probably take that, oh, there's my quotation marks one. You know, again, sensitive information being documented, where did that come from? You know, and again, they said, she said, he said, is probably what you guys have to do. But that's where I would advocate for the use of quotation marks, unless your system limits it. The abbreviation deal as well as the spell correctly deal goes to credibility. Credibility for when you're standing there on the witness stand. He went to surgery yesterday for his gallbladder, and he had type 2 diabetes. Deaf. I guess he couldn't hear. I don't know. Maybe he's mute too. I don't know. He had suckable secretions. You laugh. I didn't make these up. Okay. And the neighbor said. Maybe it was Jim Neighbor. I don't know. He's syncopal. Was syncopal. His cancer is in remission.
Fantastic.
He's syncopated. Or, this is one that's in health EMS, which goes to spell check. You guys have spell check in RMS.
We
Is
do,
it-
but it's
is
not
it
medical.
legit?
It's not
It's
medical.
not medical. Is it, do you have a customizable dictionary?
I think you can.
It is customizable.
Okay, so you have an advantage. Health EMS, I
So
hate.
those are all in there
Yeah,
now.
for
Yeah.
no other
The
reason.
wrong way.
Yeah.
And this is exactly what
They've been
happened
added
in-
by
in
certain
health
medics
EMS.
over time.
There, when you spell traveling properly,
Travel.
it gets underlined, red underline, classic, and so you hit on it to spell it correctly. And if you hit, yeah, I better change it because obviously it's misspelled. The computer wouldn't be wrong. Here's what you get. Travailing actually is a word. Took me a long time to find it, but it is a word. It has nothing to do with getting from point A to point B. I forget what it means, but it has nothing to do with vehicles or, again, getting point A to point B. And so Health EMS is got less than a rudimentary spell check system. It's horrible. No medical, no customizable dictionary. They suck, and they're one of the biggest reasons I hate them. If you at least have the ability to do a customizable dictionary, you're a step ahead of at least one other system out there. But as you can see, you know, if you had a whole page of this, I mean, we're all going to have spelling error, especially if you're narrating, okay? If you have a whole page of this, and now I start to attack your credibility and your education and your due diligence, did you go back and read this? This was acceptable to you? You know, when this entire paragraph was this way. So now I got an edge in
Yeah.
here, and now well, if you can't frickin' spell and write a little narrative, how do I know you gave that much epi? That kind of stuff. Now, is that far-fetched? Yeah. Is it wrong? Yeah, I think it is. Is that what happens in real life? Yeah, absolutely. So, spelling's important, and this, you would think that electronic charting would clean this up. Again, I think it depends on your system. You probably have a better system than Health EMS. So
Still
that's,
probably rudimentary, and the spell check works not for medical. So guys will commonly do a Word doc to do common,
To
and
find
then
the spelling.
they'll go online to medical spell check.
Right.
And then they'll copy and paste that back in.
right, and then hopefully add that to the dictionary. You know, it would be the nice.
there is
thing
a
to do.
process that changes. It's
It's
complicated.
Not easy. Okay. So that's a problem. The abbreviations also, for the same reasons, get to be an issue. And people always saying, you know, what's the matter with that abbreviation? Is it agency approved? There's a number of ways to do that, and that is to have an agency approved abbreviation. You guys get input from your clinical committee and develop that list. North Lake Tahoe got pretty creative, and they said if go to Wikipedia, and if it's in Wikipedia medical abbreviations, it's acceptable. That's pretty broad, but you'd be surprised at how creative some of the people at North Lake Tahoe can be. And I spend a fair amount of time in Wikipedia and their medical abbreviations, seeing have you guys ever heard of this abbreviation? And hey, guess what, guys? It ain't in Wikipedia. And there's thousands of them, and it ain't there. So it's not approved and everything, so don't do it again, type thing. And that's about as broad as you can get. That was a real simple fix for them. So if you can find it up there, if you can find it in Wikipedia under medical abbreviations, it's legit. Okay? And you can do something that's word. Use medical terminology correctly. If you don't know medical terminology, then use laypersons, but use it correctly. It can create all sorts of misunderstandings, and ultimately you can look stupid. Again, a couple pet peeves. I mean, if it's broke, obviously broke, say it's broke. But pet peeves, fractured or dislocated knee, and they clearly describe a patella dislocation. Well, hopefully you guys know there's a huge difference between a dislocated knee and a dislocated patella. So that's one of those things it's going to create. If you call in to Renown and say I got a dislocated knee without anything further, motor vehicle crash or whatever, and I got a dislocated knee, you're going to have an orthopedic team sitting there. That's an orthopedic emergency. And you get in there and you got this dislocated patella. How do you look? Stupid, I think. So those little things you got to be careful of. So if you're going to use medical terminology, use it properly. If you don't, keep it simple, and that's fine. That works as well. Don't have to use medical terminology, and I think many of our training programs got away from using it a number of years ago when the DOT changed their standard, right, wrong, or indifferent. If it's not written down, you didn't do it. Which gets back to our previous conversation about who's charting what and where and when. So I think that falls into it. And then sign your chart. It's a work of art. You got to take ownership for it. So make sure you're doing that. So, and I've already stated it, when you're going through this, you're trying to paint a picture. And the best opportunity that you have is in that narrative, because those check boxes, those drop downs aren't going to do it for you. They aren't going to do it justice. It's really important that you provide complete, accurate, and pertinent information about your patient. Keeping in mind, again, if it wasn't charted, it wasn't done. Now you have the ability to go back and write an addendum, and if you forget something, we'd recommend we'll talk about charting errors, omissions and commissions in a bit, but go back, it's date and time stamp, so we can see how and when and why you did that and who did it, so that makes sense. But it should be in a nice logical as well as chronological order. So you have the ability with your charting system that you actually co-mingle several formats. And some of the formats that are out there are DAR, PI, and SOAP or SOAP-E. Some charting systems, I don't think yours does charting by exception, which is pretty much what a checkbox format does. It's construed to be normal unless, and then focus charting. And I think really what you'll find if you adopt the attitude of, I did the check boxes, so I met the letter of the law, the billing department, great, now I'm going to tell my story and my narrative, that you'll actually use components of all of these. And again, we'll focus mainly on SOAP or SOAP-E, talking about this. But charting by exception is a pretty shorthand method for documenting normal findings and routine care based upon clearly defined standards of practice. This gets back to that WNL. I need a definition. Otherwise, I can write WNL except, or tell what the exceptions are. So it makes it fairly simple. But again, you've got to have that clearly defined standards of practice or predetermined criteria for clinical assessments acceptability when you're doing that. And again, if you guys you're allowing your guys to do WNL in their charting, what does that mean? Again, for a couple of you guys showed up, we did a little survey. Respiratory system, WNL, what does that mean to you?
Within normal limits.
And what does that mean to you?
They're breathing.
They're breathing?
Yeah.
That simple
For
as
an
that?
adult, a child, I mean, it's
No
it's like-
increase.
I mean, the conversation we had before you guys showed up is we're going to have 4 or 5 different
Yeah.
opinions of what that means.
Yeah.
So that needs to be cleared up
That's
if
the
you're allowing your guys to do that and you define them. And those are out there. I'm sure, and I'll share them with
Yeah,
you.
RMS
We have-
calls it normal,
Okay.
right? Is it normal?
And do they have a definition though?
Nope.
So many of these charting systems, if you're doing this, so again, I'm most familiar with Health EMS, they actually have, and you'll hit the button, it'll put out your definitions of normal, in this case, or WNL, at the bottom of your chart. So when you write WNL, somebody reading your chart can go, the attorney, whomever, can go down and look and say, okay, he was not only breathing, but he had clear bilateral breath sounds, well saturated, et cetera, whatever that definition is. And that's on the chart every, if you're prone or inclined to use that WNL nomenclature or normal nomenclature. But you guys probably ought to spell that out in policy if you're allowing the guys to do that, or RMS allows you to hit that button for normal. What does that mean and to whom? Because that's where it'll come back and haunt you 5 years from now on the stand. And when they get me up there and say, what does this mean when they said this was a normal exam? X, Y, and Z. Well, clearly, he didn't meet that criteria. The one that you see frequently on those definitions, difference between pain and tenderness. Okay, I may complain of abdominal pain. Does that mean I'm tender? So WNL or normal abdominal exam, no complaint of pain. Doesn't say anything about tenderness. So I need to address that in my abdominal assessment and clear that up. I could do that several ways. I could put normal and without abdominal tenderness, if that's what my definition includes tenderness. So there's several ways to, chart by exception, if you will, when you do that. Focus charting, again, is one of those hospital things, typically used in the hospital, but I think it's very applicable to EMS and everything, because we do focused exams, focused interventions, and we're monitoring those. What, in the hospital setting, what this refers to is we do a general assessment at the beginning of a shift of a patient in the ICU, and they're a breather. So this general assessment is all charted, it's very lengthy and SOAP format, but it's head to toe system secondary assessment if you want and everything, but clearly they're an intubated COPD patient. The focus is respiratory components here. Every hour we'll go back in and focus on the respiratory. He's still breathing on the ventilator, he's not bucking the ventilator, I'm sedating him because he is bucking the ventilator or whatever. And that's my charting for the next 12 hours, is that focused assessment. Well, very similarly, you can do that. I found this patient, I did this complete assessment, and he too is not breathing very well. And I'm gonna take him to a hospital. And we're going down the road, and I'm continuously reassessing. How are you breathing? How are you doing? You're getting worse, so my plan's gonna change. I bumped the oxygen up. Still not getting better. You're going to buy some plastic. And all that gets written out in the narrative as you go down. Again, he's got pulses, he's still breathing, he's still mentating. All those are unchanged. He's a breathing problem, here's where my focus is, and that's the way the rest of your chart will run until you get to the hospital, you get him intubated, whatever the case is. When you talk about the DAR and PIE, again, probably principally from hospital charting systems, but DAR is data, action, and response, or evaluation. If you see DEA as a charting type, is what they're talking about, and PI is problem, intervention, and evaluation. And call it what you want. I think having that concept in mind is kind of good. And obviously, we collect some data, we form an impression, and we're going to make some interventions, we're going to take some actions. And then again, if I'm going to render care, I expect a result, and I need to chart that result. And that's what both of these get to. So you identify a problem, you make some interventions, and you reevaluate that situation. Again, PI is, I got a problem, make interventions, and I evaluate how well those interventions work. So call it what you want. I think that flow and that mentality is very important in our EMS charting, because we are doing interventions. So think about if you're intervening, then you need to reassess how that intervention worked. There are, 86% on room air. You applied nasal cannula at 3 liters. Whether you stated that plan explicitly, clearly your plan was to apply some additional oxygen. When you did that, what happened? SpO2 came up to 94% with a COPD history. I'm happy with that. Cool. So there's the problem, there's your intervention, there's your evaluation of the planning. When you're doing narrative charting, again, having both objective as well as pertinent subjective information is important in that as you stage that call and you do that sort of SOAP format, which I think what most of us do. Once you do a generalized assessment, there you may identify and focus in on a particular system or problem, and that's okay. We already had the conversation about quotation marks. Technically, a chief complaint should be in quotes. Okay, and again, many of these electronic charting systems, that's a drop-down menu, and you get all sorts of bizarre stuff out of those drop-downs because you're forced to do a checkbox. So that's one of the problems. Chest pain might be in your drop-down. Well, he didn't complain chest pain. He says, I got a chest pressure, or I got a pit in my stomach. I mean, that's his chief complaint. So that for me creates some issues with the electronic side of the things. And if it gets dropped down into your narrative like Health EMS does, maybe yours doesn't, then I either go and modify that or I add to it. Okay, chest pain, complaint of chest pain, but he better describes it as chest pressure. I might add to it or something like that if I don't delete it completely. And if you don't have that ability, or if it doesn't drop down, then obviously you should capture what his chief complaint is in your narrative, and again include pertinent positives and negatives when you get to that focused reassessment. And again, we had the abbreviations talk overall. Again, the different formats that you might encounter. SOAP-E briefly talked about DAR or DAY and the PI formats. But with SOAP, and these are all similar, this is clearly, and all of you are familiar with SOAP, yes? Probably all trained on it, probably everybody in the department that's doing a chart is familiar with SOAP or SOAP-E. So not a problem. We use this in the hospital as well. It makes sense because it kind of flows. But you can't take it too literally, all right? So be a little open-minded when you look at this. In a narrative chart, this is clearly, it may be a history of present illness, the events leading up to it, what the patient is telling us when we get to that point. But all that kind of information is very subjective information, staging the call, staging the scenario for this situation. And the objective information is be inclusive of vital signs, which I don't reiterate unless they're very, very pertinent in a narrative. We do have a section for vital signs up there. I may reference, blood pressure dropped suddenly. And again, if I go back up and look at your vital signs, I should be able to see, went from 120 down to the 60s. But again, that's that ongoing assessment. His blood pressure dropped, he's unconscious. I laid him flat, tanked him up with some fluids, made him better. Is how that goes. So I don't have to necessarily hit the numbers because I have them up there and I know that. But in storybook fashion, what got my attention? The fact that he was unconscious, the fact that he dropped his blood pressure, those happened simultaneously. I just capture that in my little story that there was a change here. And again, that would be equivalent to that data in the DA or DAR format. The assessment, you take the best information that you have and you form a conclusion, a problem list, a diagnosis, a differential. Call it what you want, call it for what it is. Many, I think yours has provider impressions. Yes? Or something to that effect on it. Now, is that from a drop down?
Yeah,
And are you stuck to it, or can you modify it?
you can,
There's
Yeah,
some that are not in there that
you can put
not
not
available,
applicable
not
or not
not
known or not
Okay.
available.
But and when it drops down, can you modify it after you get into the chart at all, or is it, you stuck with it?
You want,
This is narrative.
yeah.
So you're gonna have to narrate again what you, and again, intimate, narrate, be explicit. Why I think he's acute coronary syndrome, and I'm gonna use my acute coronary syndrome protocol. I mean, that's fine in your narrative. That tells me what you assess the problem to be. I mean, he's epigastric pain or jaw pain, something vague, atypical. Someplace in there you gotta say, because of all the things I've seen and the data I've collected, I'm gonna go down the ACS protocol. So you either intimate that, state it, do whatever, that's your assessment. And that's probably the easiest way to do it, is if you've got a protocol to cover it, is data such. Gonna go down the ACS protocol. Or however you wanna state it that way. 'Cause that's your differential, that's your assessment, that's your best guess on the information that's been provided. And then this is typically difficult for EMS to do, is how do we come up with a plan of care? That's what the P in SOAP stands for. And this is why some people say, well, this is all, hospital charting. Well, no, it's not. This is a very common charting flow to use, and to use this SOAP format is very, very common. What is typically not very evident in EMS charting is a clear plan. So there's several ways to, again, just like I said, sometimes you intimate what your plan is, or your actions demonstrate what your plan is, or in a more, I know in our nursing SOAP formats, we actually have a plan under every systems exam. Sometimes we leave it blank, I really don't have a plan for it, I'm not gonna do anything. Or we have some CAN things, I'm going, to make sure everybody's greater than 95% saturated under the respiratory. That's each and every patient. However I accomplish that, that's up to me, but my goal is everybody's gonna be well oxygenated. So that's a set plan for us, and that's under respiratory. I think you have those plans. If I told you again, somebody's 86% saturated, what's your thought and goal and plan immediately? Let's give them some oxygen. Boost them up a little bit, right? You don't have a great place to do that. But I'm gonna see, again, by your actions, that obviously, in your numbers, he was obviously, and you identified he was hypoxic, you applied oxygen, and I should see someplace in there that you made him better. So, this is probably the toughest one for EMS to do. And depending again on what your chart template looks like, may not be built in. Ours, again, it's built in to our narrative template. So we're looking and our plans can change. Again, as I tell the story, my plan may change, and then I go from there. If you're familiar with the E, in SOAP-E is when we, and I think this is a nice addition, and we've already stated it, is we talk about the patient's response to therapies. So again, it's that evaluation. I did something to make things better per my plan. Now, how did that plan work out for us, for the patient, is all that does. So I think that's a nice addition, and again, one that frequently, not always, is left out from most EMS narrative charting. And again, it can be specifically and explicitly stated, it can be intimated, it can be implied, but there should be some element, if we're doing interventions, as simple as they may be, that nasal cannula application. I should see someplace in there that I made improvement. That may just be a vital sign. Maybe SpO2, my vital signs went from 86% to 96% on 3 liters. Or you can, expressly stated in your narrative, which is probably what I would do.
Each one of our procedures has an improved or not improved in.
Okay. So that helps clean that up right away. Is that required that you do it?
No, but it's also like within normal limits. What's that mean? Improved?
Right.
What to what level? That's
Right.
a very general way to say they got better or got worse.
And again, that gets back to that concept of the check, that's in your flow sheet, right?
It's in the procedure tab.
Right. So I did oxygen,
Yep.
and I couldn't have the option to put improve. So again, in court or wherever you're gonna be in front of the clinical committee, what does that mean? It means that they improve, to what level, and you can make some up, tell them whatever, and that may scoot by, but if you just use that as your backstop, okay, I did my check boxes, yes, they're improved, but in your narrative, you're being more thorough. I gave him some nasal cannula oxygen, he went from 86 to 95% immediately. Boom, it's there. Am I redundant? Yes. To show improvement in both places, clearly. But if you forgot to chart that in your narrative, you could probably get away with that improved, and you may have a little discussion, what does that actually mean to you? We'd like you to be more thorough in the future.
But if you didn't, you'd probably catch yourself, because if he was 86 and he remained 86 after some intervention, but you didn't back it up with
Right.
more thorough,
Documentation,
more
right.
more focused assessment, you're really traveling down a.
Oh yeah, now we got nothing.
Yeah.
Now we got nothing. You didn't reevaluate this patient? I thought you said he was really sick, he's hypoxic, and you were gonna apply oxygen. Did you not do that? Well, yeah, I did. Well, what happened? Again, I didn't mark that he's improved. I didn't put it here in my narrative. So now, yeah.
Or I didn't bump up the oxygen.
Right.
You know.
I didn't do it, yeah. I didn't follow through. So now you got all sorts of, again, credibility issues, questioning your care of that patient. We'll take a break here in just a second. PIE, again, problem intervention evaluation. Just put these up here, there are different acronyms for different charting systems out there. Give me 2 more slides and we'll take a break. Some examples of SOAP. My rings are tight, my shoes don't fit. The objective information, you're looking at the patient. Fingers are edematous, 3+ pitting edema of both ankles. Your assessment, you've got dependent edema, possible CHF. And again, you could do both. I could put dependent edema, as that's what I see the matter with him. Or I could go a little further out in the limb. I think he's a CHFer, based on, again, some history and stuff that we may or may not have put in here. What's my plan? I'm going to elevate his feet, explain the necessity for diuretics, getting him to the hospital. Probably like to start an IV, and patient report to whomever. I'm having trouble breathing for the last 3 days. Lungs are with rales, rhonchi bilaterally to mid-back, SpO2 is 84%, respiratory rate 32, heart rate 108. So again, very objective information. My assessment, probable CHF, plan, same thing. So those again are just examples how you might use SOAP charting. Go into a narrative with this patient. Develop sudden onset chest pain while watching TV, pain substernal, crushing radiates to left shoulder and arm. Patient states pain is exactly the same as when I had a heart attack 2 years ago. He denies loss of consciousness with difficulty breathing. Again, start to set up that SOAP format. Okay, why'd you call us? Here's why I called you. Here's what I'm seeing. This is very subjective information, and I can go on to narrate the objective part of it next.
Yes, it's coffee time. Coffee.
Recording.
Charts, no matter what charting system you're using, falsifications, errors, refusals, MCIs, abusive situations, and clearly you need to be able to deal with these. Obviously, it goes without saying, falsifying a record is kind of taboo, maybe illegal, etc., etc. So don't have to spend much time on that. Errors can be in one of 2 forms, either errors of omission or errors of commission. So if either failure to do something for the patient or doing something to a patient that causes harm or not doing it well, those kind of things. You know, do you document those? Oftentimes, it becomes glaring again in that QI process or the legal process that you didn't do something. Or maybe that's the basis of why you're in court, is because you did do something with less than a desirable outcome or not performing to standards or whatever. So it's usually, you don't have to chart these things. It usually becomes kind of apparent someplace in the process that one of these two errors occurred. Depending on what has happened, you have, you know, you obviously don't want to falsify records clearly, but depending on what happened, I mean, if you had monitor failure, there's actually a special reporting process, you know, FDA mandated reporting process for dealing with those kind of things. Some things that occur, you know, patient drops and those kind of things are probably better dealt with an occurrence report or those kind of things. And clearly you can dance around some of those. But, you know, if you have an IV that is infiltrated, you know, stating that and what you did to remedy the situation is an important part of that clinical part of the stuff. Don't make stuff up. Vital signs, and this again was the scenario that we were talking about when you got the engine, you know, charting or doing rendering care and debating whether or not they wanted to chart or not, and then the transporting rescue charting. You know, vital signs, you know, are they consistent? And again, you have the luxury, if you guys are both charting, to make sure that they're relatively consistent with each other. Whereas, and again, that's sometimes where you see the disparity when you have Group A charting, Group B taking over, and also charting on the same patient, and they don't even look like the same patient. That could be one area where, again, it's just not even close, vital sign wise. So, and again, we often reference, you know, the WNL, you know, within normal limits, or we never looked. So that's a pretty common area for people to get bogged down in and trapped when they're making stuff up. When errors occur, don't cover them up. Again, document what did or did not happen and the steps that you took to remedy the situation. How to correct errors in old-fashioned paper charting: a single line, your initials, and then the correction was the best thing to do. Don't obliterate an error. With most EPCRs, you're better off, and it sounds like your system is set up to do it nicely and cleanly, is with a date and time stamp, go back in and make the correction. Again, an omission, commission, whatever, when you discover it, and as soon as you discover it, because again, that's that date and time stamp thing, and make those errors and corrections. Don't go back in there. I don't think it won't allow you to delete your narrative, will you?
It would. It would log who did the deletion though. Like, so you could change stuff, but it would, whoever you logged in as, it would log who that was.
Okay.
So it is changeable.
Okay. But the change is noted and who did it, who entered it,
Yeah.
right? So
Even if they don't time and date stamp it, it's logged in the system.
and
So
Matt
you-
came in and
Yep.
deleted this IV start.
Yep.
Okay. So that's probably the best way with most EPCR systems, go back and do it that way. Special situations, and this is kind of driven departmentally, but if you're dealing with NCIs, you know, obviously I think our charting suffers because we've got just multiple patients. So that may change, and you may have a system to deal with that interdepartmentally. Exposures to infectious disease can bring up some, you know, charting issues and HIPAA issues. And again, most of us have some sort of avenue through the hospitals to ferret out potential infectious disease things and report back to the people involved, those kind of things. Injuries, both we cause injury to a patient or injured ourselves on the scene, again, probably are better left to that occurrence report. Part of this has to do with what's discoverable. Clearly, your charting is all discoverable, and we've already talked about it showing up in court sometime, where you can take some of these other things out and either turn it into an occurrence report, which is arguable whether or not it's discoverable or not. A QA or QI reporting system is typically construed to be not discoverable. Again, arguable, I think, in some circles, depending on how it's done. So again, if you can take some of those things out of the charting and put it into an occurrence report, altercation on scene with family members, maybe an abusive situation, again, obviously document demeanor accurately of those people involved, but you know, you may want to do an occurrence report on the side as well. Again, EMS equipment, FDA reporting special for that. We're all are mandated reporters for both child, elder, and not domestic abuse, but child and elder abuse. We need to report, and so there may be some special charting needs there. But again, be factual, non-judgmental, only the facts, ma'am, and again, report to the appropriate channels. Just as a side note, and you guys know as well as anybody that on child and elder abuse, the reporting that you're mandated to do is you report to law enforcement or child protective service or elder protective services in the jurisdiction in where it happened, where it occurred, where you found the patient. And you also, so that means, you know, if you go into Alpine County, you call Alpine SO and make that report, or however that's done. And that same thing goes for us as it trickles down. And you guys also know it's not enough, again, in our systems, in our hospitals here, we have a little bit different relationships, but technically it's not enough to tell the nurse or doc at those hospitals, receiving hospitals, that this has occurred, or here's my suspicions, and think you're off the hook. Your duty is to report to law enforcement or jurisdictional authority where that occurred. Again, hospitals that we're transporting to, there's oftentimes a mechanism in there with social services or whatever. They'll make that call for you, but if there's any doubt, again, you ought to, make sure you do it yourself and cover that base. And we've actually had that, not EMS that I'm aware of, but actually Pete Sferrazza in Reno many years ago as an attorney got into that bailiwick, and they called him on it and everything for not reporting in a timely fashion. So another situation is IFTs, and I'm assuming you guys get into IFTs, yes?
Yes.
Does RMS have a special section for dealing with IFTs? This, again, without telling tales out of school, is a huge issue up at North Lake Tahoe Fire. They do an awful lot of IFTs out of there. And in general, the charting on the IFTs is horrible, and I don't think that's different for you guys as is there or any place else and everything. And some of the EPCRs will have a different template for doing an IFT, which helps clean things up. So just talking in generalities, and again, this can all be handled in the narrative with the same concepts we've talked about. I did all my check boxes, and I may have got a lot of this stuff, but now here's my story in the narrative form and fashion. So again, in a soap or soapy fashion, why were you called to the hospital to take this patient down the road? That needs to be stated. So, you know, if it's because they've been short of breath and chest pain for 2 days, it's a rule out PE. I got this 64-year-old male self-ambulated into Minden Clinic and been worked up, and he's being transferred to rule out PE. I mean, that needs to be stated. That's going to get you paid. And there may have been a checkbox for it, cool, and we got a duplicity of it, that's okay. But this is why they called me to do this transfer. You typically in those IFTs, and again, I'm surprised that RMS doesn't have the ability to put things down like they're confined to a stretcher, they're non-ambulatory, the only way they could go was in an ambulance. And your department probably has some of those things from the billing office, because those are pretty critical. for both Medicare and getting reimbursed on these interfacility transfers or the stuff to and fro the SNFs in the area.
I remember that came out a couple of years ago. There was a big thing that they wanted us to be more descriptive of
Oh,
the
absolutely.
fact of why they needed to go with us.
When we have the docs are supposed to have a physician certification for non-emergent transport
Correct.
type of deal.
And most of El Dorado County is very aggressive with it. I go to their meetings, I watch the banter back and forth and everything, and their billers will say, "That's great, yeah, we need you to collect that, but unless you chart why it is, or challenge it even occasionally, we ain't gonna get paid on this."
So let me ask you this. What kind of difference, if any, are there going to be between interfacility transfers and, say, taking a patient back to their home on hospice? You know, you're not really delivering him. I mean, you're not really giving him much care.
Right.
I mean, obviously, you got to put something down.
Okay.
Well-
And again, not being mobile, stretcher confined, bed confined, is a legitimate reason, and there's no other services available to do it.
I mean, are you documenting, vitals every 15 minutes and an ongoing assessment if you're taking this lady home? I'm just curious.
Yeah, they're a patient, and they're going there, so whatever your departmental standards are, and everything. Yeah, I think, yeah. And again, with all our automated monitors and stuff that we have, how tough is it to push the Q15 minute timeline on that and record those once or twice? I mean, where are you going to home from here? What's your longest take home patient? I mean, half hour maybe,
Yeah.
so 2 sets of vital signs.
Are you okay with interventions done prior to our arrival on an interfacility transfer as far as medication and dosing performed by the nurse or doc,
absolutely.
that is, in their nursing notes that they give us?
If you reference them.
Right.
But, that being said, are they pertinent to your transfer? Because if you're doing this, should be a simple transfer, Reno to Renown South Meadows,
Sure.
and that PE guy, rule out PE, and he craps out, and your chart says, Minden Medical Center did interventions before our arrival. See their notes. Sitting there at Renown South Meadows, and I'm asking, I'll play the doc. So they give her heparin, or him heparin. I don't know.
See, I'll ask them and they'll say those key things, and me personally, I'll write, patient was administered heparin, I'll spell out 3 or 4 drugs. I won't put the dosages because
Correct.
they're back in their,
I
in
agree,
their
that's
notes.
fine. But
Yeah.
pertinent labs, x-rays, and interventions
Sure.
should be in that history narrative to clean it up for whoever's reading it and trying to read it in a fashion. Again, in Health EMS, we have, before we start our narrative charting, we have interventions prior to arrival. And again, just like you say,
And I think that's another one I see right there as
Yep.
far as the pump, the infusion rate, dose and dosing, because we got guys that take patients on pumps and we're not getting the correct.
well, this is
administration
a
rate.
huge issue for me with North Lake Tahoe and their medical director and everything, because again, can you guys have your variants to do heparin, nitro stuff and everything? You read the chart, and I haven't read your chart, so I don't know what you're doing. I'll take you at face value that you have, folks. Got the guy on a nitro and heparin drips, and off we go to Reno. How much? Standard concentration. I said, how much? What's your dosing for the heparin? 16 cc's an hour. Is it mixed standardly, or did they mix their own? What's the concentration? So I've got zero information when I'm reading that chart, as does the hospital. I'll just take my perspective as the QA guy, so that's what I do when I read this chart. How is that heparin mixed? And how were you infusing it? And what dose did that equal? So heparin, standard
And
concentration.
maybe buried in that chart of what the nurse mixed to that, but it's not what they told you to continue
Right.
administering it at,
Okay. So those are huge issues on those IFTs. Did you put it on a pump? I mean, these become now CCTs. You're probably billing them at a different rate because of this different level of care. So you're held to a standard, a little higher standard and everything. Now we got these, so this is CCTs, this is critical care transport now. Whether you call it that or not, I bet you your billers are billing it as such, if not they should be. But again, now we're gonna raise the bar and the standard goes up. And is that nitro and that heparin on a drip? It better be, but unless you told me not charted, not done. So one of my first questions is, was this on a pump? You mean to tell me you spent 40 minutes with this patient on a free-flowing heparin that you're doing it by the drip method? That's pretty unacceptable. So you probably have a standard that it will be on a pump. That's probably, why you maybe even have some systems would have a nurse in the back of your ambulance to deal with the pump and these drips and pick another medicine, and that's exactly what they do, I'm sure. Or you call CareFlight or whatever they'll call CareFlight, whatever. Put a nurse on board that has the pumps that can watch this. But if you got that variance for doing whatever, then, and again, the critical care transport criteria and standard would be that be put on a pump. So you need to tell me it's on a pump, it's running at this rate, which equals this dose, because it's mixed this way. So this is a huge issue that I see with their charge, their medical directors having issues with it as well. And then, again, that reassessment, which we saw in just our regular, scene call stuff, is obviously we got a problem here. It's been identified, that's why they're transferring them. Short of breath, I'm ruling out a PE. I'm obviously monitoring the pertinent stuff, the focused assessment as we go off the road. I'm looking at blood pressure, respiratory stuff, chest pain, changes, etc., as we go on. I probably also would make inferences to how well my drips are they flowing adequately, no alarms, those kind of things. Obviously, in any of the charting that we've talked about so far, I think some taglines that work really well in a lot of our situations. All other systems unremarkable, especially if you're doing focus charting. Here's the system I'm worried about, and here I get to the end of my journey. This system we've been monitoring. Here's where we are now. All other systems are unremarkable or unchanged or whatever it is from initial assessment. So things like that, simple things like that, you can clearly use, and I think beats the letter of the law, especially in that focused assessment and care. On patient refusals, I think you guys all know this is one of our highest liabilities, your medical director's highest liabilities. I'm not sure how you guys are dealing with it down here, everything, and it gets back to sort of the same conversation that we had before. I mean, if you were called and you actually encountered a patient, that is a person of an EMS call, and you're probably going to write paper on them, I'm assuming, or the captain is. We got called and there was no medical problem, he was asleep in the park, woke him up, and we went. But probably some paper is done. And it gets now, again, at what level do we do, if you got your medics or somebody doing an assessment on this patient, then you probably need to write paper of some sort. It may be very short and sweet. The guy was, we had to rouse him, but we woke him up. He said, hey, he'd been drinking, but he was fine. He was just sleeping off. A good one, has no interest in being transported. That's what that little narrative says, your EMS narrative says. He was awake, alert, oriented, said he didn't want EMS help, said here's his explanation why he's there, and he'll be getting on his way now.
In our department, we typically just do that in the overall incident narrative because it contains no patient info, and we didn't do a full assessment. Usually it's just kind of those cursory questions were answered for us to our satisfaction, and that's put in a narrative, but not an EMS chart.
Yeah, that's fine.
But that's our typical standard for most people.
And it ends up not being an EMS call and everything. You got to be careful on that because you get into those situations, unless you have provision to do it, where maybe this should be an EMS call. But it gets back to that deal, I don't wanna write paper, I just have the captain write this scene chart up, no EMS needed, or whatever, no ALS rendered, or whatever. Yet you've done a full-on ALS assessment and decided, this guy probably ought to go, but he's within his rights to say no, and so we're gonna back on out of here. And that's the only problem you have with those systems. I'm not gonna tell you how to do your business, but that's the downside to doing that, is people wanna take shortcuts. I don't wanna do a full EMS chart, so if we can just keep this on this, no ALS needed, or whatever, however it is.
Typically, the push has been at least,
Complaint.
yeah, if you have a medical complaint, then you're getting a chart. Even, you're on a wreck and I got my shoulder hurts, but it was probably from the seatbelt, but I'm totally fine.
Right.
I'm good. That's a chart.
That's fine.
If you get to a wreck and it's like, I have no medical complaint whatsoever, I mean, that's the route we've
Yeah.
typically been taking.
Yeah, that's-
When you say,
Yeah.
That's perfect, that's fine.
Physical complaint or outward complaint.
Yep. That works. Obviously, and people deal with this in different fashions, but you should demonstrate in your charting and narrate you inform the patient of the consequences of their actions, or potential consequences. You're not docs, you may play one on TV, but you're not a doc, you can only do limited things and everything. These are cookie cutter stuff that you can get any place. Many people will cut and paste, put them on a thumb drive or do whatever, so they just hit a button and paste it into their narrative on these AMAs. If your charting system doesn't have a template built in for it, many of them do. So make your own. You're up to, you could die if you don't go to the hospital type stuff. Also, part of that is, if things change, please call us back. Happy to come back. You got our number. Don't hesitate to call us. We're happy to come back. And those are lengthy. That's why I say putting them on a thumb drive, even if it's, or on the desktop or whatever, so that you can cut and paste that into your narrative on these AMAs, will help from the legal side of things. We told the person of the consequences, he acknowledged, or he's taking responsibility for his 8-year-old son, whatever the case may be. Here are the consequences. We recommend that you go to the hospital, call us back. You have the right to do this, but call us back. The other thing too, and I don't know how you guys have dealt with it, and it's kind of a bugaboo of mine, are all those patients AMAs, is that what you call them? Or do you have patient refusals? Because clearly, a majority of our patients don't have to go to the hospital, don't need any medical attention at all. And I personally resent having them sign an AMA against medical advice when there isn't any clinician in the country that would insist that you go see medical attention for this. So those are patient refusals, and I think it's nice to have the ability to do or differentiate between the two.
Right.
So, and I think there's a huge difference. So patient refusals, I think, is very different than AMAs. AMAs clearly need to be documented to the full hilt, and again, having a little template that you can cut and paste for both situations, I think is really nice and helpful. And you need to acknowledge that the patient, again, is awake, alert, oriented, rational, able to make lucid decisions and stuff as part of that. So again, this is a paragraph in and of itself, and there's different ways to handle this. On these refusals, demonstrating alternative suggestions, again including call us back, your willingness to return, but can you call a friend? We'll wait here until your mom can get here, your sister, or whatever the case may be, as alternatives. Again, all documented out nice, just takes a tremendous amount of the burden off for your folks. Just again from Health EMS, and it's probably North Lake Tahoe, but again they have just it's a very lengthy checkbox narrative of a refusal in AMA, and just in checkbox fashion and stuff. So, I mean, I can cut and paste and give those to you, or do whatever. Multiple sources, I think, for doing that if you wanted, like I say, put it on a desktop at your stations or do whatever, or make up your own. North Tower, I know a number of years ago had somebody from Wolfburg Page, those guys show up and do a legal class and everything, and so they got some canned templates, and they're very well trained, almost, even if they're freestyling it, can almost do that entire narrative, that paragraph freestyle and everything, because it just hits those elements. So overall, your checklist, documentation checklist, when you're all said and done, concise, thorough, factual, objective, and correct terminology. Part of this is going back and rereading what you wrote. That's when you're going to catch those spelling errors, syntax, context, those kind of things. It's very important. Again, don't cast judgment, be objective, and make it a little bit of a story, a chronological, logical story. Watching out for it. This may or may not work for you guys. This is actually a Sparks Fire chart. So read it. This is a SOAP. This is narrative. They don't have checkboxes per se. Possible fractured hip or leg. Again, which one? Maybe it makes a difference. I don't know. I think it does. I think you got to tell me what side is hurt. Again, same thing. Which hip? Which dorsalis pedal pulse did they take? And again, so what? They got a pulse down there. Okay. Again, which side? If it's the affected side, that goes to CMS, right, or PMS or whatever. So you sort of pick up two birds with one stone if you had identified where you actually took this pulse. Because I don't think CMS is specifically noted, is it?
It's not.
Yeah. So here's how I revised it. And again, the only thing that's missing from here, so what I did is essentially did a SOAP format, but I outlined it, so here's S, O, A, and P. Anything else other than what I'm noting here is okie dokie. And there's plus or minuses to that, but in this day and age, and in their charting system, that's probably okay. This is that chart by exception. If you found out abnormals, this is a place to tell me about it. So that being said, I'm assuming everything else is normal.
But those normals have to be clearly defined.
I think that they should be, if they're left out, yeah. I mean, I gotta assume that she's awake, alert, and oriented, whether they specifically tell me that or not. And she's able to give me this, so neurologically she's all intact, whatever, and she's moving everything, she feels everything. That's the presumption that's being made, yeah, is that there's some standard, some definitions of within normal limits, otherwise I would have addressed it here. And so all my objective information, my assessment is I think she got a right hip fracture or possibly just some right hip pain after this fall. So those, again, my assessment based on everything I've seen. And my plan, again, frequently omitted in most charting systems, is this split into position, comfort, prefer transport, consider IV access for pain administration. Okay, they don't do pain administration, but they can start the IV and get ready for the transporting agency to do. So again, in their chart, and again, something like this could look like, this could be maybe what your ALS, addendum looked like we were talking about earlier. Just brief, short, here's what we did, and now the transporting side of things.
It might be a good way if they just followed SOAP on that, if they were gonna add an initial.
I think it's clean, it's simple, everybody's familiar with it. We got called, dispatched to a shortness of breath. We actually found the chest painter. We initiated our ACS protocol. Engine 12 showed up on scene, at whatever point. So yeah, it doesn't have to be broken out like this, but it's just sort of flow. Again, telling that little story. You got called for something,
It just cleans it up, you know, because
Yeah.
it just tells that little brief story that we're
Yep.
probably looking for.
Exactly. And it's very easy to narrate.
John, can you talk just a minute about what you'd like to see as far as restraining somebody? As far as what's appropriate, because
As far as care or
no,
charting?
well, charting,
Charting,
which would lead to care, but yes.
You're right. So charting, you chart what you did and why you did it. And then probably, and it absolutely comes from hospital nursing stuff, but it gets extrapolated to EMS, I think necessarily, is, and again, we build them into our templates, that if we've got a restraining deal, and if we were restraining somebody, we're checking CMS Q15 minutes. That's a hospital standard. I don't know any place where it's addressed in EMS, but CMS, if you know, especially as you get to hard restraints and those kind of things. So we just build it into our templates that if we are using restraints of any sort, that we're going to do CMS checks. We also document why we restrain somebody. So clearly, crew safety is an issue for us, but protecting tubes and interventions may be a part of it. It, you know, maybe involve law enforcement and because they've handcuffed this dude to my gurney. But again, who did it? What and what kind? Soft restraints versus hard restraints.
And what position they were in?
Clearly,
Yeah.
and you know, and obviously, then now you get into the excited delirium stuff, and then you take that a step further and get into chemical restraints. You know, so again, how and why clearly is important if you're doing physical restraints. I think position is key, but CMS is one of those things that comes out of the hospital that cleans things up for you. In a court of law, who's going to be sitting there reading that chart and making expert judgment on it? It'll be some doc or nurse sitting in there saying, if you would, you know, had this handcuffed patient in your ER, what would you be doing? And I'd say, well, our policy in the hospital says we document Q15 minutes on these checks.
Thanks.
That's a protocol now, no?
Does that answer? Is that where you're
Yes,
going?
it was.
So this is not one of your charts. Are you guys off the record still? Or oh, you can leave it written by North Lake Tahoe, one of the guys up there. And I'll just, and again, with our template. So look pretty familiar so far, right? So now they're going to start narrating this. And when you're done. Okay. Okay. So overall, what do you think?
fairly thorough.
Yeah, there are a lot of information there. And I would absolutely agree with you. That being said, and again, so in our templates, and they use the same template we use. So after that narration, which is supposed to be history, okay, so let me back that up. So those 3 pages is actually supposed to be history of present illness, which will be one of the things that I'm going to modify, because there's obviously objective information in here and assessment qualities in this narrative. So again, in this template that we use, it doesn't all belong there. It's very inclusive, but there's a better place. So here's what, again, in the way these charts are laid out, each system is hit, and this information, especially in parentheses, is dropped down. Okay? So this is all dropped down from some checkboxes that they had done. They do use WNL, and then they have a definition list at the end of the chest. All drop-down information from the checkboxes in this particular system. So he's not written anything here. This is yellowed. Did this guy need a 12 lead?
Meh. You seem to be me.
Yeah, I think you make that argument. But in the template under cardiovascular, just standard boom, every one, this is here. 12 lead EKG rhythm interpretation. And in this case, it was left blank. So my question is, here, they've got this line here, but nothing there. So it prompts me did they do a 12 lead? Where's their assessment of that? Where's their interpretation? So I'm sort of looking for that. And then I also asked the same question, does this guy deserve it? Yeah, he's an old guy with simple episode. Yeah, I think so. Now where is it? So it's not there. So is this omission? Or is just one of those things? And again, we have the ability to remove that. So it becomes a distractor for me at this point if you don't have that information there, if you aren't going to provide that information. So here's the revision, which essentially is unchanged here. Initially, there's the initial chart. Didn't really change anything here. Again, this is all drop-down stuff. Initial chart over there. Again, all drop-down stuff. No changes here. Where you're going to start to see the changes made is here. So again, if you need a reminder, so what essentially I did is I'm going to stage history of present illness. Why were we invited to this party? And again, wife's relaying, dispatch is relaying this information to us. What I don't need here is assumptions, guesses, my impressions. I don't need that yet. It's not the history. That could go at the end, and you probably see it at the end. It doesn't need to be here. How about this line again, yellowed out, just to draw our attention to it? And this was in the original, but I left it here, but yellowed it. Patient appears intoxicated and smells of ETOH. What are your feelings on that?
One's
It could be
subjective,
construed
one's
as-
objective.
yep.
You know. Smells of ETOH, I'm good with that.
Appears versus you're saying smells.
It's like, beer cans all over the ground, you could say that, patient was drunk, do you know, type of thing.
Possible smell of ETOH. Patient just says he did.
I like the fact that, if they relay to you what they've had, you know what I mean? That's,
Patient states.
that's a cleaner,
yeah.
that's a cleaner
Absolutely.
avenue,
Absolutely. And again, they did that up here. States that he had 3 glasses. So I just put this in here just to mainly see a reaction. I'm sort of okay with it in the context here. They are making some judgments, but some assessment up, in light of having 3 glasses, he appears intoxicated and smells of ETOH. Pros and cons, give and take. We could discuss that on both sides of the equation. I think what you guys appreciate clearly, and Dennis, you just said it, is when you have objective information, like you said, Jeff, beer cans all around, smells is my assessment. He relates or admits to having you know, if it's a Jack Daniels or whatever the case may be, much cleaner in that chart to write. And again, I think in the context, yeah, I'm so-so with this one. Not against it, not 100% for it. And again, it could be argued just like the conversation we just had here. I just put it there. That's one of those kind of yellow flags when you're.
No, if it's written patient's obviously drunk, that takes it to a whole nother level.
Whole nother level.
I mean,
Exactly. And that's why I said I get, since you guys are on page and you
Yeah.
aren't going to be doing that. So you just got to be careful with those kind of things. And that's the only reason it was there. The other thing I excluded from this initial history of present illness is, again, the stable vital signs and all that stuff. You're going to tell me that later in this chart. So again, ongoing with the original chart, patients continuing to give me some more history, background history, social habits, those kind of things. He was normal a little bit ago, went into the bathroom, and then things changed. Oh, and by the way, this patient really is pretty reluctant to go to the hospital. I mean, I'm getting that right now, that's, needs to go someplace, important piece of information, because what it does is signs in my story, it says, I got a reluctant patient. I got a patient who's probably sick, deserves to go, but he's reluctant. So I'm going to need to do some convincing here. In the physical assessment, I rewrote it, and again in ours, and it may or may not fit into your charting system. Again, we have this template. When I would do this, I'd do a neuro exam and do a complete neuro exam as appropriate for this patient. And I don't rely on the drop-down stuff in this particular charting system. So if you were doing a system assessment, I think in your narrative, documenting the neurostatus of this patient's important, right? So this is sort of the focus on this guy who had a syncopal episode. So I'd do a neurological assessment to the best of my ability, the information that I have. Whether you label it as such in your charting system is up to you guys, but clearly you're going to spend some time and focus on this element. Head and neck, I think you can clearly, you find the boo-boos or not. This could be a WNL if that were the case. It's not. Chest is within normal limits. Respiratory is probably a component to the overall assessment of focus for this patient. And then the huge focus is that cardiovascular assessment, because that could be, again, the root cause of his syncope. And again, remember we talked about that 12 lead? I think that it should be done. It was done in this case. And I think that it should be noted here. That's important information. Normal 12 lead is okay. 12 lead shows no acute ST changes. I mean, that's why we did the 12 lead, right? In case you had an occult MI that, we want to see and look at all those leads, all that territory. So something to that. What I object to for a 12 lead rhythm interpretation is normal sinus rhythm. Well, I could have got that from that lead 2. I know we got no clue in lead 2. What we don't, we have a lead clue 2 is I'm looking for ST changes. Okay, I'm looking for that MI, for that STEMI that didn't present itself characteristically. So that's the pertinent positive and negatives, if you will. Why'd you do the 12 lead? I want to see if he had a STEMI. Well, tell me he did or didn't on that. And depending on your charting system, is there a place in your system for doing a 12 lead to make an interpretation as a flex field or any of that?
I think in the EKG box, but it's pretty limited if I'm not
Yeah,
mistaken.
you can pick
right?
like bundle branch blocks.
Yeah,
you can pick
nothing
P-
Yeah,
more.
again, those are rhythm interpretations and
Peace.
not, again, so if you said in that drop down, or your flow sheet, you did a 12 lead, I'm sure is there. Someplace you need to interpret that. And again, why'd you do a 12? Ask yourself, why'd you do this?
There's no ST.
And so you want to pertinent positive or negatives in that. And so in your charting system, the best place for that is going to be in the narrative. And why'd you do it? It's cardiovascular. So again, even if you left out these other assessments because you didn't find, and you did all their systems unremarkable, we hit neurorespiratory and cardiovascular as our focused assessment. And what's pertinent there, and again, if you're to this point, 12 lead we thought was important to do. Why? I want to make sure he wasn't a STEMI. Tell me he was or was not a STEMI when you get to that point. It's not as simple as I just depicted it, because he's fallen with this syncope and he's injured himself. And so then you have some other points, again, the original one over on the right. I think they put this part of this assessment, and it should probably needs to go to down to the extremities. So that's where I would put most of this pelvic assessment. So I'm again looking for true pelvic pain in this trauma exam, if you will, and then deal with the femurs, the hips, and CMS down below. I think you should note this hip exam, i.e. palpation, deformities, lesions, and CMS in here, and it was kind of omitted under the extremity section. The original chart was under the pelvis, so just the location. I think the information was principally there. It's just I question where you put it in, again, the template that was provided. So we've done this assessment, okay? He's told us he done fell out, he's hurt himself, he's reluctant to go to the hospital. So, okay, let's road test him. And so now below that, so again, chronological, logical, storybook fashion, he tried to walk. He started to fall over, we caught him. Okay? Continued to complain of this left hip pain, yada, yada, yada. Wife and he finally agreed that we'll go to Reno. And again, this can be put elsewhere. And this is, we had an interesting discussion. The guy who wrote the chart was in one of our first classes up there. Does anybody else chart like that? Meadows without incident and without negative change? Meaning deleterious change is how his interpretation of it. It seemed to me like it was kind of a double negative. So again, we've described all these problems, put them in the ambulance, we've been keeping an eye on them, nothing's changed. So without change is how I would write that. What's the chief gonna write?